Hotbed Talk.
This piece is presented by Kay Mitchell, Senior Research Manager for Critical Care Research, NIHR Biomedical Research Centre, University Hospital, Southampton in the UK. Have a listen.
Hello, I'd like to thank EBPOM London for inviting me to talk about my experience of setting up business cases in relation to perioperative medicine in the UK. So my background is that I've worked with UCL for a number of years previously, who were an early adopter of cardiopulmonary exercise testing, and they set it up originally as a research tool, but then clinicians became interested in the results of the tests and started to ask for tests to be done on their patients for clinical evaluation. So we started to charge using an external contractor model, which enabled us to charge the NHS for these tests. So cardiopulmonary exercise testing, as you will know, is used to enable surgical risk stratification. We did it originally in elective colorectal surgery patients who we tested them preoperatively, and we were carrying this out at the Whittington Hospital in North London. As the service expanded, we were able to expand to other clinical sites connected with University College London. We published early data on outcomes. We were able to obtain grant funding to look at a robust evaluation model. And we ran the service, as I said, as an external contractor using a charitable organisation. Some years later, I was involved with the setup of a service similar to this at Southampton, but this was a much more refined model. So this was a service that we established in-house, so the NHS took ownership of it, but that was because we were able to get NHS England support to commission the service with the use of tariffs. And so this was again a cardiopulmonary exercise testing service. And if you're going to run this as a business, you need to identify an income, which in this case is a national CPET tariff, and you can charge £265 per test. And then you need to identify what your costs are related to that. And those costs might be fixed and they might be variable. And in this case, these fixed costs are the cost of your medical staff, and if you use them, technical staff, because some places will choose to do all of their tests using the medics to deliver the tests, and other places will use technical staff such as physiologists and nurses to deliver the tests, and then the medical staff will analyse them and report on them remotely. You need money to fund your CPET equipment, to depreciate that equipment, and what I mean by that is that any piece of kit will have a lifespan, and you need to make sure you put money aside to purchase new kit to replace it when it breaks down. And you also need an annual service contract so that you can get prompt servicing and repair of your equipment so that you can keep your service going. You'll need access to resuscitation equipment or purchase your own. You'll need a robust database that you can use to collect data on all of your tests and analyse your results so you can show the performance. And you'll need administration support. And that administrative support can be refined to being very, very hands-on, where you have immediate response to your clients and to your patients, or it can be more haphazard, but there will be a cost associated with what level of support you get. And then your variable costs will be related to disposables for the tests that you do, and also accreditation and education of your staff, depending on how many you have. So now moving on from that, we're looking at perioperative medicine as a pathway where we're trying to deliver patient-centred multidisciplinary integrated care. And that's partly in the light of documents that have come out from organisations such as the Royal College of Anaesthetists. And this perioperative medicine pathway allows you to look at how you would manage your patient right from the beginning of the surgical pathway right through to the end of the surgical pathway. And so you're looking at things related to how you manage them before they go for an operation, during the operation, and as they recover from that operation. And one of the particularly important things that is part of that is prehabilitation, and how you try to change behaviour in order to improve people's experience of surgery. And that changing behaviour will take into account a multimodal intervention. And that might include things related to physical, psychological and nutritional fitness, as well as smoking cessation and alcohol reduction in particular. So if you have a pathway, you will have components of that pathway probably that all of your patients will need to receive, and you can charge using tariffs for all of this. So they will all need some sort of health screening. And then once that's done, you then may have a subgroup who need increased individualized assessment. And that individualized assessment will be related to things like exercise, psychological intervention and nutritional intervention. And once you've done that more detailed assessment, you might then want to have some specific interventions for a subgroup to bring them into a better position for surgery. And you might also want to send them to specialist groups for further input, such as a high-risk clinic, sleep apnea referral, or referral to a diabetic team to get their diabetes more under control. So perioperative medicine in the future will look at delivering a pathway which has broad-based digital educational support, multidisciplinary team reviews, individualized assessments and treatments, and some pre, peri and post-habilitation. And in order to deliver all of those components, you'll need a series of specialists. And these will include anaesthetists, surgeons, physicians, physiotherapists, physiologists, dietitians, psychologists, administrators, nurses, and I'm sure there's some other individuals that I haven't mentioned here. You may not be purchasing all of those individuals for all of the time, as in all of their hours in the day, but you might be purchasing part of them, so a number of PAs of their whole time, or a percentage of the whole time equivalent that they work for your organisation. So then, in order to pay for all of those components, you need to identify tariffs that you can then charge your commissioners in order to pay for that. And there are different tariffs that might be appropriate, such as advice and signposting, which comes up with a tariff, or exercise sessions in the hospital, which you can assign a tariff to, or a sleep apnea respiratory review, as you can see from this slide. And then you need to work out how many patients within your population are going to require these additional inputs, so that you can generate a total number of tariffs that gives you your income, against which you then pay out your specialists for their time in order to deliver that service. So in conclusion, when you're developing your business case in the UK, you need to identify your tariffs that you can generate that income from, and those tariffs will be paid by your STP, or moving forward, your integrated care system. You need to work out what your costs will be, and these will be fixed as well as variable. And as I said, you need to negotiate for your staff in terms of PAs of their time, or percentages of whole time equivalent. Thank you for listening, and I look forward to joining in the panel discussion.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.